Anterior and posterior scalars. This presentation includes photographs from Fundamentals of Periodontal Instrumentation. Presentation and videos created by Lori Close. Scalar videos recorded by Tanya Morley. In this presentation, you will review proper patient and operator positioning, review instrument design characteristics of scalars, identify the purposes, uses for anterior and posterior scalars, determine the correct working end selection, review visual cues, demonstrate correct angulation for scalars, identify how to move the working end of the instrument, identify characteristics of the instrument stroke, identify characteristics of the bite stroke, differentiate between different stroke directions and areas of use, differentiate between anterior and posterior scalars, identify correct angulation and adaptation of scalars, identify the calculus removal stroke, identify the correct cutting edge selection, and view videos of the SH5, 33, and 204 SD scalars. Review of operator position for use of scalars on anterior teeth. Anterior teeth. Maxillary and mandibular anterior surface toward. The right-hand dominant operator will sit between 8 and 9 o'clock, or the left-hand dominant operator will sit between 3 and 4. You may find the 9 o'clock position for right-hand dominant and the 3 o'clock position for left-hand dominant operators works best for maxillary anterior surfaces toward. You may find the 8 to 8:30 position for right-hand dominant or the 3:30 to 4 o'clock position for left-hand dominant work best for mandibular anterior surfaces toward. Maxillary and mandibular anterior surfaces away. Right-hand dominant 11 to 1, left-hand dominant 11 to 1. Both the right-hand dominant and left-hand dominant operators would sit at 11 to 1. Most operators choose 12. Review of operator position for use of scalars on posterior teeth. Posterior teeth. All surfaces toward the operator, right-hand dominant 9 o'clock or left-hand dominant 3 o'clock. This position is mandatory for sextant 1 buccal for right-hand dominant operators and for sextant 3 buccal for left-hand dominant operators. Operators are allowed a 1/2 hour adjustment in basic seating positions for surfaces towards them. Most right-hand dominant operators will choose 8:30 for all other posterior surfaces toward them. Most left-hand dominant operators will choose 3:30 for all posterior surfaces toward them. All posterior surfaces away from the operator. The right-hand dominant operator will sit between 10 and 11, while the left-hand dominant operator will sit between 1 and 2. Review of instrument design. The face. The face is the top of the working end. In this slide, the face of the scaler is yellow. Back. The back is the bottom of the working end. The tip. The tip is the last 1 to 2 millimeters of the working end. The tip is adapted to the tooth for calculus removal. Cutting edges. The cutting edges are formed where the face and the lateral surface meet on the working end. Where the face and the lateral surfaces meet on the working end. In this slide, there would be 2 cutting edges. Cross section. The cross section of a scaler is triangular. You can see that in the center photo in green. The cross section is triangular. Review of instrument design. The inner or inside and outer or outside cutting edges. The inner or inside cutting edge is going to be closest to the handle. The outer or outside cutting edge is going to be further from the handle. Review of instrument design. Functional shank. The functional shank is the portion of the shank that allows the working end to be adapted to the tooth. The functional shank in this photo begins above the working end and extends to the last bend in the shank nearest the handle. The functional shank is color-coded in yellow, or you may see it as light green. Review of instrument design. The lower or terminal shank. The lower shank is the section of the functional shank that is nearest to the working end. Another term for lower shank is terminal shank. The ability to identify the lower shank is important as the lower shank provides an important visual cue for the clinician in selecting the correct working end for the tooth surface being instrumented. In this photo, the lower shank or terminal shank is orange. The purposes of scalers, the areas of use. Scalers are periodontal instruments used to remove calculus deposits from crowns of teeth. The crowns are covered by enamel. Sickle scalers are primarily supragingival instruments and should not be used on root surfaces. Root surfaces are covered by cementum. Scalers may be used subgingivally on enamel if the tissue allows. How to select the correct working end of a scaler for posterior teeth. The functional shank goes up and over the distal surface of the posterior tooth. The lower shank is upright and parallel with the distal of the posterior tooth. The back of the working end is towards the gingiva. The inside of the working end is against the distal. The handle is toward the midline. Visual cues for adaptation. How do you tell if the terminal 1/3 of the working end is against the tooth? The heel will be rotated or rolled away from the surface you are instrumenting. Visual cues for adaptation. How do you tell if the back of the tip is directed apically when instrumenting proximal surfaces? The lower or terminal shank should be upright with the tooth and lean into the tooth in a facial or lingual direction. This direction will depend on the surface you are instrumenting. If you are instrumenting on a facial, the lower shank would lean towards the lingual. If you are instrumenting on a lingual, the lower shank will lean towards the facial. We must be careful not to over-exaggerate this lean, and we'll discuss in lab. Visual cues for adaptation. How do you tell if you've instrumented 1/2 way or more across the proximal? The lower or terminal shank will be positioned at or past the line angle. This visual cue is primarily used for posterior teeth. It is important to view the instrument design when using this visual cue. If the instrument has a short working end, you may need to have the lower shank past the line angle to assure you have reached halfway across the proximal. If the working end is longer, you may only need to have the lower shank at the line angle to assure you are halfway across the proximal. Angulation. The correct angulation with scalars is 70 to 80 degrees. The lower shank of the instrument must be lean or be tilted slightly into the tooth surface that you are working on to achieve correct angulation. The lower shank is colored in green in this photo to show you the slight tilting or the leaning of the lower shank into the tooth structure, giving us the 70 to 80 degrees necessary. Incorrect angulation. 90-degree angulation is incorrect. In this photo, you will see the lower shank not leaning or tilting into the tooth surface being instrumented. The lower shank in this photo is red. This is incorrect angulation. Moving the working end. Wrist activation is recommended for calculus removal with hand-activated instruments. Instrumentation occurs in short strokes, millimeter movements. Assessment and reassessment strokes are light. Calculus removal strokes require firm lateral pressure, locking the tip against the tooth, and wrist activation. The calculus removal stroke is in an up and away motion. Pause and rest between strokes. Preparation for the instrument stroke. My fulcrum finger is straight, supporting the weight of my hand. My fulcrum finger presses down against the tooth. My index finger and thumb apply pressure inward against the instrument handle. I lock the tip 1 to 2 millimeters onto the enamel surface. These are all things you should be asking yourself in preparation for the instrument stroke. Preparation for the instrument stroke. There are many steps that we need to be aware of. Let's look at each one individually. Me, I assume the correct clock positioning. My patient, I establish the correct patient chair and headrest positioning. My equipment, I adjust the light and delivery system, making sure all items are within reach. Think ergonomics. My non-dominant hand. I grasp the mirror and establish a stable fulcrum with my non-dominant hand. My dominant hand. I grasp the instrument, verify I have the correct modify pen grasp. My finger rest. I establish a fulcrum near the tooth being treated while staying out of the line of fire. The tip of my finger is secure on the tooth surface. My fulcrum finger is straight, acting like a support beam. Is my finger placement in the modified pen grasp still correct? My adaptation. I adapt the tip 1/3 of the working end, 1 to 2 millimeters. I review all visual cues for adaptation. My angulation. I establish the face to tooth surface angulation of 70 to 80 degrees by tilting or leaning the lower shank slightly into the tooth surface. My stabilization. I pressed against the tooth with my fulcrum finger, applying inward pressure against the handle with my index finger and thumb. My activation. I activate a short stroke in an up and away direction. I use controlled strokes and the instrument remains in contact with the tooth. Rest my muscles. At the end of the stroke, I pause briefly to relax my fulcrum finger, index finger, and thumb. My next stroke, I continue to either reassess, initiate another calculus removal stroke, or move to assess the next area. The bite stroke. This is putting it all together. Your fulcrum must be close to the tooth you are working on and out of the line of fire. Your fulcrum finger is poker straight. You position the working end just apical to the calculus deposit. You review your visual cues for adaptation. The lower shank slightly leans into the tooth surface you are working on to attain the correct angulation of 70 to 80 degrees. You double check your modified pen grasp. Your fulcrum finger presses down against the tooth. Your index finger and thumb apply inward pressure against the instrument handle. You lock the cutting edge on the tooth. You use short and controlled strokes. The cutting edge stays in contact with the tooth. You activate the bite stroke in an up and away direction. You pause briefly and relax your ring finger, index finger, and thumb. You reassess the area you just attempted to remove the calculus from. At this time, you would either initiate another bite stroke if the calculus remained, or you would move to the next area with an assessment stroke. Stroke direction. There are 3 stroke directions we will introduce to you with scalars. Vertical. This stroke direction is most commonly used on anterior teeth and mesial and distal surfaces of posterior teeth. Oblique. This stroke direction is most commonly used on the facial and lingual surfaces of posterior teeth. Horizontal. This stroke direction is most commonly used at the line angles of posterior teeth and the midline of facial and lingual surfaces of anterior teeth. We will be showing you how to use this horizontal stroke on the distal line angles of posteriors and the midlines of anterior facials. The anterior scaler. This is a double-ended instrument with different instruments on each end. The SH5. A white arrow points to the SH5 end of your anterior scaler. The SH5 end is designed to be used for light interproximal calculus removal. Instrumentation with the SH5 begins at the line angle, not at the midpoint of the tooth. Clinicians will use the SH5 only for interproximal calculus removal in process 1. One cutting edge is used for surfaces toward, while the other cutting edge is used for surfaces away. When the operator changes seating positions for anterior teeth, surfaces toward and away, they must also change cutting edge selection. SH5 anterior scaler. Anterior scaler, the 33 end. The 33 end of the anterior scaler is designed to be used on all surfaces of anterior teeth with medium to large deposits. Begin instrumentation placement at the midline. One cutting edge is used for surfaces toward, while the other cutting edge is used on surfaces away. When the operator changes seating positions for anterior teeth, surfaces toward or away, they must also change cutting edge selection. Posterior scaler. This double-ended posterior scaler has mirror images ends on each end, the 204 SD. This posterior scaler is designed to remove light calculus deposits on posterior teeth. The 204 SD is designed to be used on light deposits located interproximally. The 204 SD may be used on all surfaces of posterior teeth. The inside of the working end is used on the distal surfaces. The outside of the working end is used on the buccal, lingual, and mesial surfaces. 204 SD scaler. On the maxillary arch. Learning periodontal instrumentation. Please refer to your readings in Fundamentals of Periodontal Instrumentation, Stages of Motor, Psychomotor Development, and Strategies that will make psychomotor learning easier. Thank you for viewing, and have a great time practicing with your scalers.